All right, I think it's time for us to get started. You can go to the next slide. All right, so this webinar is going to be recorded and available on the National Action Alliance website, part of the AHRQ website. Please use the chat function throughout our session today to engage with us and to ask any questions. There's also closed captioning functionality at the bottom of your screen. So I also want to begin, before we really get into the meat of it, by thanking Allina Health for their commitment to the 5 aims of the National Action Alliance. We encourage all interested healthcare systems to visit the National Action Alliance's website to understand the commitment process. Please check that out. I will put a link in the chat for that as well. Go to the next slide. This is session 2 of a 3-session series we're doing as part of these webinars through the National Action Alliance. The first one was in October about the influence of leadership behaviors on patient safety, on healthcare workforce well-being. The session today is about how to address workforce burnout as a driver of quality and patient safety. And the one that we're doing in December is going to be about turnover, what to do about the turnover issues in healthcare right now as a driver of safety and quality. Lots of good resources on all of those previously recorded webinars. You can check them out on the National Action Alliance website as well. So we can go to the next slide. Please, as we get going today, keep these questions in mind as you listen to our speaker, who I'm going to introduce in just a moment. What can healthcare organizations change in their care delivery processes to reduce staff burnout? You're going to hear about that today. And then what outcomes can be improved by addressing burnout? Those are 2 things to keep in mind as you're listening today. And we'll go to the next slide. Also, please feel free to use the chat function to share with us what you would want to improve in your organization to reduce staff burnout. Now, now that you're thinking about that, let me go to the next slide. I want to introduce Dr. Colin West. Originally from Seattle, Dr. West received his MD and PhD in biostatistics from the University of Iowa in '99. He went on to complete his residency in internal medicine at Mayo Clinic and joined the faculty in internal medicine in 2004. He's currently a professor of medicine, medical education, and biostatistics at Mayo. He's also a director of the Mayo Clinic program on physician well-being and was named the first medical director of employee well-being from Mayo Clinic in 2022. Dr. West's research over the past 2 decades has focused on medical education and healthcare professional well-being and has been widely published in prominent journals, including Lancet, JAMA, Annals of Internal Medicine, and JAMA Internal Medicine. I have to say, it's one thing to be doing well-being research right now. It's another thing to do well-being research and put it in prominent journals. And that is there's maybe a handful of people who can do that in the world, and you're going to hear from one of them right now. And with that, I'd like to hand it over to Dr. Colin West.
Great. Well, thank you so much, Brian. And thank you to the Alliance for hosting these sessions. I think these are really important topics as we think about what we're hoping to accomplish in medicine in service of our patients and our communities. And so I applaud the Alliance for bringing everyone together to advance our common understanding and hopefully allow us to build a community that is solution-oriented as we move forward. So I'm going to take one piece of this today and talk about healthcare worker burnout, what it means, what it's associated with, and a broad framework to help us think together about what the menu of solutions might look like. Next slide, please. These images really illustrate what we hope for and often do experience in our interactions in healthcare. Whether it's with patients, colleagues, families, these are important relationship-centered positive interactions. And as we try to help people live better, healthier lives, we want to have these experiences of joyful moments, human connection. We also recognize, however, that these are aspirational to some extent as well, because oftentimes, although we do experience these positive moments, there are many stressful points as well, where people get frustrated, they experience distress at work. The interactions are not everything that we want them to be. And so as we think about our direction toward increasing well-being, thriving, flourishing in our healthcare practices, we also need to acknowledge that part of the path to get there involves looking at the distress factors in the face, really, and not pretending they don't exist. So what I'm hoping to do here in the next 17, 18 minutes is share a little bit about some of those distress factors, not so that we can dwell on them, but so that we can understand them to be able to bend them back toward that positive interaction, that aspirational goal of thriving and flourishing in our careers in medicine. Next slide. So I mentioned some of the distress aspects, and one of those that is discussed a lot, especially in the last 5 or 10 years, is burnout. This has almost become colloquialized, where people will have a tough day or a tough moment and say, "Oh, I'm so burned out today." But what does burnout really mean? So it's been developed as a construct over at least the last 4 decades, and it's got a specific definition. It's a work-associated phenomenon with 3 main dimensions: emotional exhaustion, depersonalization, and a sense of low personal accomplishment. I won't say a whole lot more about that sense of low personal accomplishment, but I am going to suggest that we put a pin in that for the future, because although in our early studies, this was not as strongly associated with key outcomes, including patient safety outcomes, we've since learned that this is strongly related with experiences such as imposter phenomenon or low self-valuation, which are very common among healthcare professionals and are also associated with key outcomes. And so we may need to be coming back to that. But emotional exhaustion and depersonalization have really been the foundational elements. Next slide. Emotional exhaustion is illustrated by this statement. This comes from what is widely regarded as the gold standard for assessment of burnout, the Maslach Burnout Inventory. "I feel like I'm at the end of my rope." This is emotionally having nothing left to give, feeling husked out and unable to tap into any emotional reserves to meet the needs of our patients or our colleagues. Now, I will say all of these are measured on continuous scales technically, but for simplicity in communication, we found that if these are experienced at a frequency of once a week or more, that is associated with a host of consequences that I'll share in just a couple of minutes. So keep that in mind as you hear about not just emotional exhaustion here, but next, depersonalization, which is on the next slide. Depersonalization is illustrated by this statement, again from the Maslach Burnout Inventory. "I've become more callous toward people since I took this job." This is fundamentally antithetical to our core ideals in medicine, where we work in a human-oriented profession, where maintaining empathetic relationships and caring deeply about our patients and our colleagues is essential. And so this idea that we might feel callous or treat other human beings as objects with any frequency at all is very problematic. And again, if this is experienced at least once a week or more, that's associated with consequences. Now, these can be put together. And so if emotional exhaustion and or depersonalization are experienced once a week or more, that can be classified as experiencing a meaningful degree of overall burnout. Again, technically, these are continuous domains and there's debate about how they get combined, but we've demonstrated that that combination does matter. Next slide. The frequency of these experiences is worth mentioning as it's experienced over time. We started looking at this on a national basis in partnership with the American Medical Association back in 2011. And we found an overall burnout level using that definition I just mentioned of about 45%. It's bounced around a little bit pre-pandemic, but actually 6 to 9 months into the pandemic, we saw lower burnout. This might be surprising initially, but it actually speaks to this honeymoon or heroic phase of disaster response that has been documented in the literature for many disasters. And in healthcare, we leaned into our meaning during that early phase of the pandemic. Unfortunately, that doesn't last forever as our reserves become exhausted. And we saw 1 year later the highest levels of burnout recorded, at least in our modern history of assessing this. Across physicians, more than 60%. We saw similar numbers among other groups of healthcare professionals. And in certain groups, for example, ICU nurses, emergency department physicians, we saw burnout levels approaching 85%. The literature post-pandemic as we emerge is suggesting some improvement, but we clearly have an endemic issue across healthcare. So burnout is prevalent. It's problematic just from a value standpoint. And next, we're going to see what other consequences it's associated with. No matter which group you have the greatest affinity for, there is a consequence of physician and more broadly healthcare professional burnout. I'm showing you data here specific to physicians. There's a growing literature in other health professions as well. In the upper left, we see direct patient consequences, medical errors, suboptimal professional behaviors for physicians, reduced patient satisfaction, especially in the long term, and even racial biases, where residents who are experiencing burnout have greater degrees of implicit and explicit biases against others. Importantly, when burnout improves, those biases also improve. And that's a bottom line. We are not our best selves. We cannot do our jobs to the best of our abilities when we are experiencing burnout. And that's a connection to patient safety, to quality, and to the environments within which we work. We also know that burnout's associated with access to care. Physicians who experience burnout are more likely to turn over, as are their staffs. They reduce their clinical hours. They leave their jobs looking for different practices, all of which is very disruptive to our patients and their care. From a more individual standpoint, we know that medical knowledge acquisition is adversely affected by burnout. Mental health concerns are related, and even some public safety issues where physicians with burnout, after adjusting for fatigue, are more likely to have motor vehicle crashes or near misses. A study we did with the Harvard Business School a number of years ago, looking just at physician burnout and job turnover, so no other health professions, no other consequences, estimated that this cost the US healthcare system about $5 billion a year, or $7,600 per physician per year. And again, this is a gross underestimate because it's just looking at physicians and it's just looking at the cost of turnover, let alone all of these other consequences. I mention those numbers because sometimes in healthcare, when we're dealing with budget concerns, we hear, well, we'd love to address this, but we can't afford to address well-being right now. And the reality is we're already paying for it on so many fronts. So it's not that we can't afford to address well-being. We can't afford not to address well-being. Next slide. We've cast this as a public health crisis because of the consequences and the prevalence. So if we think about the physician training pathway, we have 100,000 learners, 500,000 physicians dealing with meaningful levels of burnout at any given time, more than 1 million nurses, plus all of the other healthcare and biomedical science professionals. Next slide. This becomes then a rhetorical question. If something is this prevalent, is it largely rooted in individual deficiencies, or is it actually a system problem where dedicated, well-intentioned individuals may be doing the best they can, but they're working in an untenable system? And this is one key point to recognize where there is a direct analogy where we can learn from quality and safety's advances over the last 25 years. So let me say just a little bit more about that on the next slide beginning. Most on this call, because of your interest in quality and patient safety, will be very familiar with To Err Is Human from the Institute of Medicine, what is now the National Academy of Medicine. To Err Is Human was published in 1999, and I've been involved in medicine long enough to remember what our approach to quality and patient safety was prior to this report. And I'm exaggerating slightly, but I think those of us who remember those days remember that really a lot of this was about trying to figure out who to point the finger at in errors. Who was responsible for not doing their job properly? And how can we discipline and correct them so that the error doesn't happen again? To Err Is Human came out and said, you know, that's really not the issue. We're missing the point. The vast majority of people in healthcare are passionate and committed to the well-being of their patients. They don't want to make mistakes. They are committed to doing good. But despite that commitment, errors do happen. So To Err Is Human came out and said, maybe we need to think about systems to better support and protect both patients and healthcare professionals from human fallibility. Next slide. Deming has said 85% of the reasons for failure relate to systems and process rather than the employee. So in essence, to improve quality, we need to fix the workplace, not the worker. Certainly, there is some component of this that is an individual responsibility. This is shared, but we need to emphasize how we are working in the system frame to be able to improve quality and patient safety. And there is a direct analogy to how we need to evolve our thinking, and have been pushing to evolve our thinking in well-being. After all, next slide, as Paul Batalden at the IHI has said, every system is perfectly designed to get the results it gets. So on the one hand, this is an indictment potentially of our current healthcare system, because the well-being results, much as the quality results that we've worked on over the last several decades, are a direct result of the way the system is designed. On the other hand, this also presents us with an opportunity, because if we're committed to designing our healthcare structures with well-being as a foundational element, we can design those to get the well-being outcomes for both our healthcare professionals and our patients that we all deserve. Next slide. One 30,000-foot view model to think about this is the job demands resources model. And what this model stipulates fairly simply is that distress results when there is a chronic imbalance between high job demands and the resources to meet those demands that are not adequate. Now, the key to recognize in medicine is that every task we engage in medicine is actually a high cognitive demand task, because there are risks, there are side effects, there are complications, and even routine decisions that we make almost as a matter of course, almost as a reflex, are actually generating cognitive strain, whether we're consciously thinking about them or not. Because the stakes in medicine are high. We need to be attentive. This means that we need to be serious about making sure that the resources that allow us to do our jobs remain adequate, as opposed to what we commonly experience, where we need to do more with less, and there's maybe a promise that will reduce demands down the line sometime, but it's not clear that we truly experience that. That may be something we touch on a little bit later in the discussion. Next slide. A little bit more specifically, Christina Maslach and Michael Leiter have described 6 workplace domains, what they call the areas of work life, that drive either burnout or engagement and well-being. And most of these are fairly intuitive. So workload is important. If our workload is excessive, our well-being suffers. Interestingly, in medicine, this isn't simply monotonic in relationship. We actually thrive on working hard. And so we don't generally, although it sounds nice from moment to moment, want Friday spa day. We want to work hard, we want to be challenged, but we don't want to be overwhelmed, and we need to be able to recover as we come back to work in the future. So workload needs to be something that is sort of in that sweet spot where it is challenging but sustainable. A sense of control and autonomy is important. Often in medicine, we don't feel like we have a sense of agency because we are subject to decision-making by others. And that's damaging to well-being if it is sustained or excessive. Intrinsic and extrinsic reward are important. Intrinsic reward is really that internal sense, that meaning, that purpose that we're able to connect with. Extrinsic reward is not just about compensation. It's also about genuinely being appreciated and valued for the work that we do, and feeling that from the people that we're trying to help, the practices that we're trying to work for. That doesn't mean that our patients owe us gratitude. This is not a burden that patients should bear, but it is deeply rewarding for healthcare professionals to have those positive bidirectional relationships. Community is important, and increasingly we're understanding this isn't just about connection. This is really about aspiring to a sense of belonging. We learn from our DEI colleagues about how important this is. And I'll say a little bit in a few minutes about a specific intervention that can help foster some of this. Being treated fairly and with respect is essential, and having our individual values align with what we see in our practices and in healthcare in general are also essential. Next slide. Putting all of this together, if there's one takeaway when I think about or talk about solutions to well-being, I ask people to consider what I call the MVPs of well-being: meaning, values, and purpose. Every effective solution that promotes well-being in medicine connects with one, if not all three, of the MVPs. So if you're thinking about an intervention or a policy, if it promotes meaning, values, and purpose for healthcare professionals, it's going to help well-being. If it detracts from meaning, values, and purpose, then it's something that you should think carefully about, because it's going to diminish well-being, increase distress, potentially increase burnout. So the path to well-being runs through the MVPs: meaning, values, and purpose. Next slide. I won't go through a roster of solutions. There are myriad solutions out there. It is important to note that there is not one size fits all answer to all of this. But for graduate medical education, the ACGME has a website. The AMA has practice transformation efforts oriented around practice satisfaction. The National Academy of Medicine that I already mentioned has a clinician resilience and well-being website. And the US Surgeon General has identified health worker burnout and well-being as an advisory priority area. So there are a wealth of repositories of resources that are out there that are worth digging into around this larger framework for thinking about what the drivers are and determining what the most important drivers may be for you as an individual or in your practice setting, as it's different from your neighbors or other practice settings. Next slide. I do want to share briefly, however, that one example that I mentioned as we head into the discussion. And these are what are called compass groups or physician engagement groups that are small groups where physicians get together to share experiences in a directed way to promote problem solving, connection, community, and well-being. This has been published as the slide shows here. The next slide will begin to show a little bit more detail on what these are about. We published 10 years ago a version 1.0 of this, where we had facilitated assigned small groups of 6 to 8 physicians working through a guided topic-based curriculum over 9 months. And we were able to demonstrate that that experience led to reduced depersonalization and increased meaning from work. So good things for well-being. We followed that up to see if we could deliver this in a less involved, more efficient way that might be easier to scale. And the second version, what became Compass groups, were self-formed groups without a trained peer facilitator. These groups met every other week for an hour, and they committed to dedicating at least 15 minutes of that hour at the beginning to the assigned topic or curriculum. And I'll share some examples in a moment. What the groups told us was once they got started, they kept going, frankly. We paid for their meals. So they made the time to meet with their colleagues. We paid for their meals. And this was trialed again about 10 years ago. Next slide. The topics rotated across 3 broad categories: meaning in work, teamwork and connection, and personal resources. Some examples are shown on the slide here, and these were intended to promote reflection as a group and as individuals, brainstorm solutions together, and without deliberately trying to solve other people's problems, at least bring out conversation and a sense of shared experience so that people would feel more connected, less alone, less unique in some of the experiences they had, but also be able to tap in to the amazing stories and meaning that they all experienced in their medical careers. Next slide. The conclusions of the study, and the next one, please, were that every domain of burnout improved markedly. Rates of positive depression screen also improved, and these physicians were less likely to contemplate leaving the organization in the next 2 years. So both individual and organizational benefits, direct link to other literature, as I shared earlier, relating to quality and patient safety. Next slide. And so this showed that a modestly funded small group-based curriculum could positively impact physician well-being. Next slide. And the next. Some operational points that are worth noting, because they aren't completely solved at this point and they may look different from site to site, are whether these need to be in person versus virtual. We continued groups during the pandemic when they needed to be virtual. I think personally in person is always better, but virtual is better than being disconnected completely. And our groups continued to be quite successful. Are these mandatory in your organization or are they voluntary? I personally feel strongly they should be voluntary opt-in. The menu of solutions for well-being differs from person to person, and having people be able to select off that menu matters. It needs to be the same team over time rather than having people drop in and out in too large a group, because you need to build a culture within that group of safety and shared experience. They can be assigned or self-formed, both work. They can be self-facilitated or facilitated with a trained facilitator, both work. And finally, we've only trialed this among physicians, but we know other organizations have looked at multidisciplinary teams or similar groups in other professions with similar benefits. So I think there's a universe of opportunity out there beyond just what we've done within the confines of our randomized trials. Next slide. So as we head into our discussion in a moment, a few action items to contemplate for all of you. First, you need to be able to assess and acknowledge issues so that you can address them. So consider a measurement plan for burnout and other key dimensions of well-being that you care about to identify areas of strength and opportunity. The National Academy of Medicine has resources to help support and guide this. That assessment can help you identify which driver domains need the most support in your local environment. And then you can map solutions intentionally to those domains. So for example, you might want to build community at work if you feel like people are isolated and disconnected, in which case you might draw from evidence-based interventions like Compass-style groups. And then finally, think about solutions in broad categories, because both individual and organizational levels of responsibility need to be represented. And it's important that you have a menu that doesn't just ask people to give entirely of themselves, but also demonstrates that the organization is investing in the individuals and is also trying to improve learning and working environments so that people can bring their best selves to their work and to their patients. Next slide. My contact information is here. Please feel free to reach out to me at any time. But with that, I'm going to go to the next slide and hand it back over to Brian to take us into the next phase.
All right. Thank you, Colin, for that. I love hearing about this. I've been citing this work for a long time, but what you just did was you provided us with a very evidence-rich kind of background and discussion. And I love that you pulled out the Compass Group as an example of a potent fix that can be done locally. So here's something that strikes me, and I want to invite folks to bring your questions and put them into the chat, because we're going to go through those questions as well. But I want to ask you this, Colin. At Duke, we have a large meeting of about 200 social workers and case managers that it was happened every month for many years now. And they used to have that meeting, and it was over the lunch hour. People would go and they'd grab a bag like from Jersey Mike's or from Chick-fil-A or something. And they go sit down and they'd be on their phone while they're kind of half watching the continuing education in front of them. And one day we changed that, and we made it a buffet style kind of. It was usually Chinese food. So you'd like have tongs and you'd have to put some lo mein on your plate and you'd have to grab an egg roll. And what that did was it meant that the line to get into continuing education was very long. And what did they do? They talked to each other while they were putting food on their plate. And the tone of the sessions changed entirely. And here's the thing, Colin, it was cheaper to do the Chinese food. So then to go with the grab bag stuff that we were doing up until that point. So it was actually a budgetary thing that kind of put us in that position, but the ratings of the sessions went up, the attendance of the sessions went up, and people were using them as a focal point for just, connecting with their brethren across the system. Do you see that as like another kind of example of a compass-like effect?
I think certainly there are parallels. And I think one of the keys, where there are many forces in medicine that are driving us apart from one another. We have overwhelming workloads. We interface with electronic systems so that our interactions with colleagues often are indirect through electronic messaging, for example. And all of those things play their role, no matter how big a critic you may be of, electronic medical records and things like that. They play a role in patient care. They're a tool. They have taken an outsized influence in pulling us apart, however. And so I think anything, frankly, that restores some of that connection, builds that human interface, and it can be subtle. It can be an unexpected benefit of something you didn't necessarily plan, which is sort of what I'm hearing with the buffet style.
Yeah.
But I think if you step back and think about the why behind why that might stimulate things, you're bringing people together in a fundamentally human profession. And it doesn't matter if you're an introvert or an extrovert or, what your dynamic is there. We work in a profession that is people oriented. And so we do better when we get out of our office silo and we interface with somebody. And it doesn't mean you have to force it artificially. It will actually happen organically if you just bring people together, and they will start sharing experiences. Now, the nuance with the Compass groups is, I think there are different layers of conversation that people can have. So there's the informal, hey, I'm chatting with my colleague about things and I like these people and they're keeping me human. And then there's the somewhat more in-depth, we're going to talk about something that is a shared experience. And we want to focus on that topic because it's a workplace specific sort of thing. The Compass groups are more of that aspect, forcing a topic and then letting it go where it goes. I think both can be valuable. You can formally push people in a direction, but you can also provide opportunities for, the water cooler talk, if you will, that rarely happens in medical practices anymore. I feel that in my own practice. I am scurrying from room to room, from office to office. And even in the main work area, if I'm talking with my nurses or my desk staff, often it is only about an order or an appointment. It's not, hey, let's take 30 seconds and, hey, your kid had a big soccer game last weekend. How'd it go? Or, whatever the interpersonal kind of touch point happens to be. And I don't want to suggest that those interpersonal touch points are a panacea for what's going on in medicine. We cannot ignore that everything else in medicine needs to be addressed simultaneously. But I think we don't allow ourselves the best possible opportunity to connect with meaning in our work if we ignore things that actually are within our sphere of influence. And this is one in local practices that I think is within our sphere of influence and actually could be used by leadership to say, we actually care about the environment. And while we're trying to pull the bigger levers, we're going to support, we know you've become more disconnected. We're going to support trying to help you maintain those connections.
That's really good. I like this, and there's I want to remind people to please put your questions in the chat, and also just based on what you've learned today, what will you do to reduce staff burnout? You can put that in the chat because we're collecting that information from y'all as well. Colin, there's a question or a comment here in the chat. Where does the experience of workplace violence land in burnout and drivers, or is something else like trauma? Or something that's like trauma versus burnout?
Yeah, so I want to be careful and not suggest that burnout is the only distress domain in all of medicine, because that is, it's incorrect. A lot of these different experiences are yes and kind of dynamics. So there's a growing literature on moral injury, the relationship between depression and burnout, trauma with COVID, post-traumatic stress disorder that might be COVID pandemic related. All of these things, I think, overlap to a degree. They're all connected with this larger human experience of distress or well-being. I think workplace violence touches on multiple of those domains. I think certainly from a burnout standpoint, experiencing workplace violence is it certainly negatively influences that driver of respect. You're not treated with respect or treated fairly. It doesn't align with the values that we bring to medicine, and then we see it's one thing to be a victim of workplace violence, which can come from colleagues, patients, families. Runs the whole gamut. It's one thing to be a victim of that. It's a second thing if you don't see your organizational environment support you properly. And that's where the values domain of drivers of burnout can become just a wound on top of a wound. And so I do think that workplace violence overlaps with the contributors to burnout, but workplace violence causes a lot of other problems as well beyond burnout.
I 100% agree with that. I think that if you frame workplace violence from the perspective of organizational response to workplace violence / organizational support of staff exposed to workplace violence, then you see that there's a big system role there that is often kind of clumsy in its attempts to kind of make things better. And I also agree. I violently agree that that burnout is not, or emotional exhaustion, for example, is not the only metric out there for kind of well-being. It's just really, really good. It's very responsive to interventions. It's very predictive of outcomes. It's a pretty good little metric, and it relates to moral injury and moral distress and exposure to disruptive behaviors and workplace violence and a sense of physical safety. So it's interesting to kind of pull this back to the perspective of how the organization responds and supports the workforce in the face of a really bad day for that worker.
Right.
Same thing with second victim support and peer support, programs just kind of in general. So I guess on the one hand, it makes me think that a compass or a compass-like program or approach should be framed as part of an organizational support infrastructure, right? People could think, if you could think of it as a targeted intervention, like a SWAT team. Here's a unit that needs some help right now. Here's an intervention we can deploy, but also it should be probably one of many arrows in the quiver to take out when needed. Across, because it seems like it's agnostic to the work setting type and the role of the healthcare worker. Is that fair?
I think that's fair. I mean, what we know about these groups continues to evolve. But I think one thing you said there, Brian, that's really, really important, and it actually resonates with a couple of the comments that I'm seeing in the chat here, is to avoid the conclusion that I think a lot of us get a little cynical about over the years, that we've identified one silver bullet solution to these problems. And that actually breeds cynicism. And especially if the solution feels like something that's a little more in the individual responsibility domain. We've done studies nationally that show that physicians and other healthcare workers have higher resilience despite having higher burnout levels than the general population. So resilience is a good thing. Please don't misconstrue. It's something we need to maintain, strengthen where we can. But the idea that that is the bell cow of our well-being interventions, to me, is misguided, and it promotes this sense of almost victim blaming for healthcare professionals. Where things like compass groups come in is, okay, this is something that is within your sphere of influence. It helps build potentially your own skill set. And if space can be made for this by your organization, it can help your organization model that it's trying to move its levers as well. It can't be the only, as you said, arrow in the quiver. It's got to be part of a much larger menu. And the magnitude of those drivers and whether they're going to be responsive to things like compass groups depends on the local environment. If you're in a setting where you are 50% staffed and everyone is having to basically no vacation ever and, double shifts, I don't think meeting to talk about that and build your sense of community is going to solve that emergent problem. I'm not naive to this. That's an organizational red light flashing kind of emergency. And if you're in that kind of a situation, you're in a different level of crisis. What we're talking about here is one arrow in the quiver that needs to be combined with a multifaceted approach that hopefully an organization can be forward thinking about enough to avoid getting to the crisis point where they can't even see the light of a solution.
And all those arrows need to be evidence-based. They need to be strongly evidence-based because there's a lot of well-intentioned people right now in the well-being space that are muddying the waters. And by that, I mean people who think that the answer to everything is yoga or the answer to everything is meditation. And there's great data behind those things, but that's offensive if, like you said, you're physically, spiritually, and emotionally exhausted, and someone says you should learn how to put your ankle behind your head. That's not fair. That's not helpful. And I wholeheartedly agree. I want to bring up another thing here, Colin, because you brought up compass, and I know it's not like the magic wand that you wave that fixes all of burnout. It's one tool that can be deployed in a very specific way. And what you've learned is that these MVPs, these meaning, value, and purpose-driven conversations are an intervention that helps to reduce emotional exhaustion. And the staff like it. They like it so much they want to continue it right on their own. That's a real, in terms of feasibility data, that's a powerful indicator that it's going well. What if you looked at the exact opposite of that? If you think of these meaningful interactions on a spectrum, and on the one hand you have a kind of facilitated compass group meeting with 6 to 8 people in a preordained kind of topic for the meeting. But what if on the other end of the meaningful interaction spectrum, you have physical violence of a coworker? or just mean-spirited comments, disruptive behaviors of a coworker that really make you question, do I want to continue to work here? Do you think, in that sense, that those unprofessional behaviors by coworkers, and by the way, I think burnout's driving those unprofessional behaviors. So let's not kind of gloss over that. But do you think that severe kind of unprofessional behaviors is like the opposite kind of an intervention of compass groups, which drives down well-being, whereas compass groups drive up well-being?
Well, I don't think there's any question that when people have those kinds of toxic experiences, and I see in the chat from Katrina, I'm just terribly sorry that anyone has an experience of being assaulted at work by anyone. We need to be safe in our work environments, and it's beyond ironic. It's actually deeply morally damaging to people when you are giving of yourself to help others and become a target in that process. It's very damaging, and it leads to cynicism. And we need to see strong organizational responses. We need to rally around each other. We need to have zero tolerance for these kinds of events. I think you're right. Often these interactions come from, if they're coming from colleagues, they can be a reflection of distress or burnout. When they're coming from the public, often they are a reflection of societal ills. That doesn't make them any more acceptable, however. And I think that's a key distinction. This is never something that we should accept or say is just part of the job. And we need to see this modeled in our work environments. And we've developed a model at Mayo for well-being, and experiencing a healthy work environment was the first well-being pillar. Physical and psychological safety at work are fundamental aspects of the healthy work environment. This is something everyone needs to be responsible for, and leaders need to institute policies and practices that support that. And it needs to be visible, because the most valuable resource in every healthcare organization are the staff. They are who deliver the mission. They are who take care of patients. Nothing in healthcare happens without the staff. So it's everyone on this call. It's the individuals, person by person. And we have to make sure that we're demonstrating, this will end up on my tombstone, what we resource demonstrates what we value. Mm-hmm. So we need to invest in people to demonstrate that we value them as our most valuable resource in our organizations. And so, again, I get a little afield from your question, I think, but the idea that coming to work and not being safe is detrimental to well-being makes perfect sense to me. It's a fundamental part of the safety net that we need. And frankly, it should be a minimal expectation. You should come to work and expect to be safe and able to do your job to help other people. And as leaders, I know many people on this webinar are in leadership roles. This is something, as much as I would like to say, the term well-being centered leadership or wellness centered leadership should go away. It's just leadership. I think if we can help people be a little bit more intentional about, as a leader, how do you create those safe spaces for everybody? You're going to see burnout reduce. You're going to see engagement and well-being improve. And you're also going to start seeing people be more engaged in this shared responsibility to solutions rather than protecting themselves, which is where so many people are right now, because they don't feel safe in their local or national environments around healthcare. So again, we all have a role in this together. Individuals can only do so much, and we need work unit supervisors, institutional leaders, the movers and shakers nationally to all be doing more to try and create learning and working environments that truly allow us to thrive so that patients get what they deserve, as do we.
So just in terms of making this portable and taking some of what you've said today and bringing out some of the nuggets or the bullet points, I really like your meaning, values, and purpose comment. You made a comment that if you're going to do an intervention, you should ask yourself, is this going to impact our sense of meanings, value, and purpose? And if not, is that really going to help with the well-being of the people that you're intending to target with that intervention? We actually in our lab say something very similar. We do these bite-sized interventions where like, what can we do for 4 minutes a day for 4 days or for 2 minutes a day for 8 days and still see a difference 6 months and 12 months later in your well-being scores? And what we focused on in our bite-sized interventions are positive emotions. Like if we can help you feel grateful, if we can help you feel hopeful about what's coming next, if we can help you feel interested in what's going on in front of you, if we can increase those positive emotions, we can increase well-being. And we have to look at anything that's claims to be a well-being intervention. Well, is it going to do something to increase your exposure to positive emotions? But I heard you say you have a similar litmus test that we use for positive emotions. You would apply meaning, and values, and purpose in that same way. Is that fair?
Yeah, I think that's right. And I think what it allows is a chance to move away from specific micro tactics that may or may not be connected with other approaches or with the evidence base. And this is the common thing that happens. Leaders and individuals typically don't want their people to be distressed. So a lot of good people try to do things, but they don't have a framework for thinking about or anticipating whether it's going to work. So an idea off the shelf, or they read something on a blog somewhere and they say, oh, well, we got to do something, so let's do that. And they're not actually reflecting on, is it what my people need? The best way to foster engagement is to actually engage. It's a tautology, but I don't say it jokingly, because so many leaders feel like they have to have the answer, when the answer is actually to open the door for your staff to tell you what they need. And your job as a leader is a facilitator of getting people what they need, not solving the problem yourself, but opening the door to the solution. So I think where I think meaning, values, and purpose is so helpful is that it allows people to step back to medicine is a values-oriented profession. So people are used to thinking about, well, I do what I do because I want to help patients on their journeys of hope and healing. Wonderful. This is what we all wrote on our applications to our jobs or to professional training schools, those personal statements. Those are all correct. We drift from that when we try to implement a specific solution. And the framework of meaning, values, and purpose allows us to step back and say, are we still on purpose? Are we still on task? Does this make sense? Let's not waste limited resources on something that's a Band-Aid and that's not well aligned with a fundamental principle. On the other hand, hey, somebody's got a great new idea. It aligns. Let's run it through this filter. Does it help people connect with their why? Does it allow them to feel purpose-driven in their work? If the answer is yes, hey, you know what? This might be a winner. On the other hand, we see a lot of policies come in that aren't designed with well-being in mind. I do this at Mayo now in my medical director role. Somebody will have a practice policy that comes in. And part of my job is to say, look, I see that this is going to get you a certain objective in your area that you're paying attention to. I want to bring in some discussion of how this is going to affect people. What is this going to do to their ability to connect with meaning, values, and purpose in their work? Usually, these other groups haven't even thought about it. And then once they do start thinking about it, sometimes they can draw a connection and say, you know what, this is actually really good. We can change our presentation to honor these things and show people how this is going to be beneficial and how we're committed to that. Or we need to rethink our proposal because, you know what, you're right, this is going to pull people away from what matters. We need to think about this differently.
Colin, let me ask you a question and maybe we can start to close it out with this. This has been a fantastic discussion. I love geeking out about this stuff with you. You know, Vivek Murthy, the Surgeon General, has drawn these parallels between the patient safety movement and the well-being movements in healthcare. And I know there's not data here, and you thrive when someone, you know, gives you a lot of evidence. You find the right evidence to focus on. So I appreciate that about you. So I might be taking you out of your comfort zone here a little bit, but what predictions do you have about, if you look at the trajectory of patient safety, where when To Err Is Human came out, we did not have patient safety officers or patient safety officer training or budgets or journals. You know, there was not an appreciated place where science on patient safety could live at that time. And you look at now, we're kind of in this weird place where journals are starting to do more perspectives on well-being and lots of complaining, but it's remarkably difficult to get even randomized controlled trials published in top tier medical journals because they'd rather focus on other things. Do you have any predictions about where the well-being movement is headed? Is it going to take 20 years for well-being to do what patient safety did?
I certainly hope not, because we've already been working at it for more than a decade as a community. So I think we need to learn, and part of the reason I draw the analogy with the quality movement is it's not enough to just recognize that there are parallels. We need to learn from them so that we can accelerate faster, because the need is too great for our healthcare professionals and for our patients. We all deserve that. I continue to be optimistic about this for a couple of reasons. The more negative optimistic reason or negative reason for optimism is we have no choice, because our system is careening off a cliff, and we can't go off a cliff. So we won't have a healthcare system if we don't address these effectively. And I believe we're going to respond before we get to the true crisis point. The more positive driver of my optimism is the community of people that are invested and engaged in this has grown immensely, even in the last 10 years. So there are more and more people paying attention to this. And I think that groundswell of support and work is moving forward. Organizational science is hard, and we need more collective, industrial and organizational psychologists, for example, need to be part of this work from outside of medicine to come in. The more we build those connections, the more effective we're going to be. I see in the chat, for example, there are some examples. AHRQ has a funding opportunity. The Laura Breen Foundation has been part of developing this. It's under renewal right now with discussion in Congress. We'll see what happens with political moves of, what funding will be available. But those didn't exist at all 5 years ago.
Right. Yeah.
So there are major resources that are being brought into bear just around well-being experiences. And in addition to that, we're starting to see sub-aims of other grants where a third aim is looking at workforce well-being, for example. So it might not be the lead aim, the priority, but it's part of the grant, part of the direction. I think we're going to see some of that emerge to help us learn a little bit more. And it's going to become much more normal that attention to well-being is part of our mandate in healthcare. There was a point in the chat about, the primary value at Mayo Clinic, the needs of the patient come first. So can we ever really take care of our healthcare staff if the needs of our patients come first? And the reality is we have to recognize that we serve the needs of our patients by taking care of our healthcare professionals. So they're actually 1A and 1B. They're not on a different level. And so the more we can push that forward, that we actually honor our mission in medicine by protecting our healthcare workers, the better off we're going to be driving towards solutions. And I'm optimistic that we've made a ton of progress in the last 10 years. We're going to continue to accelerate that, but we can't take our foot off that accelerator.
I couldn't agree more. I think that what the To Err Is Human report did for patient safety, I think COVID did for well-being. I mean, the awareness is just, the awareness is there. We just don't have the solutions yet. And it's that uncomfortable position where we know there's a problem. We don't know exactly what the best way to do,
Right.
what way to deal with it is. So if we can live out a little bit more of that uncertainty, I think I agree. I think it's not going to take a full 20 years for us to get there. We already have so much, progress to show in this space. This is fantastic. I don't know if we can put up the last slide again real quick here. I just want to say thank you again to Colin for a wonderful discussion and presentation today. The recording is going to be available on the National Academy, on the National Action Alliance website. And next month is our third in the series on resolving the workforce turnover crisis. Please check it out. If you haven't registered, do that. You can use the link there in the chat. Colin, thank you for your time, and thank you for your service to this really fundamental need, and just doing it with grace and doing it with evidence-based rigor. It's always a pleasure to read your stuff. It's a bigger treat just to be able to chat with you.
Oh, my pleasure. Thank you to everybody else. And please feel free to reach out if you have questions, comments, things we didn't get to. You've got my contact information, and we are all in this together. We will all rise together.
Hear, hear. All right. Lots of gratitude there in the comments too, there, Colin. I think we're going to go ahead and turn off the recording here.